Okay, so as usual, before we go in detail, nice to have a look on the introductions of diuretics. So the first thing you need to know is why we need diuretic or when we are going to use diuretic. So diuretic is mainly for the management of few conditions such as anuria, hypertension, and edema. What's the meaning of anuria? Anuria is referred to your kidney cannot produce urine. This condition we call anuria. Why? Uh, your kidney cannot produce urine because your kidney have been undergo a condition we call failure. So when your kidney have either is failure or inflammations, then your kidney normally will stop produce urine. Okay, quite clear. When you face a patient who is anuria, definitely you need to ask them to do further analysis to make sure that whether they have nephritis or renal failure. So renal failure for beginning, the anuria condition will not happen until certain extent. Only anuria conditions uh, happen. Okay, that's why you have to bear in mind when you come to uh, the state that showing the anuria symptom. Definitely, the patient is undergo renal failure. If the patient had a history of renal failure, so you may ask me why? Because you still remember, like I do discuss this, the biochemical parameter only increase after uh, 75% of our kidney is damaged. As long as your kidney is still able to perform 25% of functions, then the parameter we are not going to increase. So that's why it's very difficult to detect a patient when when they have renal failure from beginning, or we can say it's renal damage from beginning. So diuretics is mainly for few conditions: anuria, hypertension, and edema. Edema I don't need to mention, and everyone know. Edema may be due to inflammations in the local locations, special locations such as brain, your eyes, uh, and then kidney as well. As long as your tissue undergo inflammations, definitely they are come together with edema. That one you need to remember. Because why? Because later we're going to discuss later. Because when your kidney undergo inflammation, they produce a lot of mediator. This mediator are going to encourage uh, vasodilation, and your blood will going to flow there and then accumulate there because of osmotic pressure. Okay, and then hypertension. Sometimes hypertension we also use directly as well. Okay, quite clear when we are going to use into that. Basically, there are few symptoms that encourage us to use direct. One is an urea. Second one is hypertension. The third one is edema. Okay, how's your diuretic going to perform? Meaning that the mechanism of actions, basically they have two main mechanism of action. One is increase the glomerular filtrations. Another one is decrease the renal sodium and water reabsorptions. So increase your glomerular filtration means that you encourage the blood flow more to your kidney. So your kidney able to perform and excrete out the water so that to achieve the diuretic effect. So in some diuretic drugs, they're going to decrease your renal solution. Once your renal solution was not reabsorbed, so the renal the solution we're going to maintain or going to stay in your tubule or your loops, then the sodium will cause an osmotic pressure. So the water from surrounded area will going to enter your tubule or your lobes. So by doing so, you're able to produce more water in your urine for excretion purpose. Okay. So still remember last to yesterday, we do uh, go through 3 or 4 classes of diuretic. So actually, until now, we have 6 classes of diuretic drugs. The first one we call osmotic agent. Second one is carbonic anhydrase inhibitor. Okay. Once you saw the words inhibitor, meaning that is a compound that's going to inhibit something. For this case, it's going to inhibit an enzyme we call carbonic anhydrase. The third one is thiazide and thiazide like compound, and then followed by organic acid, potassium sparing diuretic, and also ADH antagonist, which is few of them we have gone through, isn't it? So it doesn't matter. Today we'll focus on two. Then the coming lectures we're going to focus on the others. Okay. So quite clear. So until now you need to remember basic concept of diuretic is uh, there are two main important mechanism. One is increase the glomerular filtration rate. Second one is decrease the renal sodium reabsorption or water reabsorption. So they have 6 classes: osmotic agent, carbonic anhydrase inhibitor, thiazide-like compound, organic acid, potassium sparing diuretic, and ADH antagonist. Okay. So even though they are different, different, different category. You can categorize them differently based on the mechanism actions. But basically, they have share the same mechanism action. One, the inhibiting the water or sodium ion desorption. Meaning from the words you need to understand properly. Some of them inhibit water reabsorption. Some of them inhibit sodium ion reabsorption. Some of them inhibit both water and sodium um, reabsorptions. So these are the basic concept you need to understand. So how we are going to determine whether which one is better than which one? So actually depend on how much or how extent the sodium ion are going to excrete out into the urine. Meaning that the intensity of diuretic is depend on how many sodium going to excrete out into the urine. Okay. If let's say drug A able to excrete more, meaning that RA is better than the others. Okay, quite clear. Is one of the uh, concept you need to understand. So clear everything. So we go to another slide. Okay, this slide try to show you the mechanism actions. No, there's no mechanism action. There is a side effect of each of each group. We have 6 groups, isn't it? So they give you few example of each group and also the adverse effect. So later we are going one by one. Don't worry. So as usual, before we go in detail, you need to understand the basic physiology functions of your kidney before you're able to appreciate the diuretic drugs. So this is the basic unit of your kidney tissue. We call it as nephron. Okay, nephron consists of few parts of glomerulus, proximal convoluted tubule or PCT, Hendy-Rhodes distal convoluted tubule or DCT, and collecting plug field. Okay, I give you a few seconds, you go and match which one is belong to which one. Okay, glomerulus is here, proximal convoluted tubule or PCA is here, PCT is here, and lobe of Henry is here. So distill convoluted tubule DCT is here. And this is collecting duct. So clear? Because why you need to understand the anatomical structure? Because different drugs will add on different locations. That's why you need to understand. Okay. So the functions of the nephron is perform filtrations, reabsorption, and secretions. Okay. This one I think you all of you know already, isn't it? So once you perform these three main functions, you're able to control your blood pressure. Either it's reabsorb or decrease the reabsorb of water or excrete out the water or excrete out your sodium. So when um, you need to increase your blood pressure, normally your kidney will going to reabsorb more sodium and water as well. Once you reabsorb more sodium, automatically will reabsorb more water into your bloodstream because of osmotic pressure. Okay. Another structures or cell you need to understand is juxtaglomerular cell. Where is juxtaglomerular cell? Look at the figure here in the left bottom. Okay. Juxtaglomerular cell is a junction or connecting area between the epsilon and distal tubule. Okay. How to differentiate which one is epsilon, which one is epsilon? A and E, epsilon and epsilon. Epsilon is the water, the blood uh, come in, and epsilon is the waters come out, the blood vessel come out. Oh no, sorry, the bloodstream come out, and epsilon is the blood going in. So how to differentiate? Okay, you look at the diameter. Epsilon definitely is largest in term of diameter compared to epsilon. Why? Because they are going with these structures, you are going to introduce a pressure on the glomerulus, a force pressure. In is largest, and then out is smaller. Then congestion may happen here. So once congestion happen here, may create a pressure. That's why able to push element out from your glomerulus into your capsule Bowman capsule. Okay, clear. This connecting area we call it as a juxtaglomerulus zone, or the cell we call it juxtaglomerular cell. So basically, these locations are going to produce renin. Renin, still remember? The precursor for RAA cascade. RAA cascade. Without this renin, you are not going to produce angiotensin. Okay. Angiotensin going to contribute in rising your blood pressure. Okay. By by causing vasocontraction and also causing the productions of aldosterone. Okay. Aldosterone, we're going to cause sodium, ion, and water retention, means that going to reabsorb sodium and water from your kidney. By doing so, your blood pressure will going to increase because of blood volume is increased. Okay, clear? So this is another slide that you need to understand. So I do highlight a few points here. So first thing you need to remember, not all the uh, element we're going to excrete out or filtered out. Those are largest in molecular size. We are not going to filter out, will remain in your uh, glomerulus. Okay, clear? This few things you need to understand. Second thing is 99% of your sodium we are going to reabsorb. Either it's through your tubular or through your lobes. We are going to reabsorb 99%. Only small amount we're going to excrete out. So this 99% of sodium we are going to reabsorb through two pathways. One is cation exchange. Cation exchange refer to positive positive potassium ion exchanges. Second one is chloride ion transfer. Chloride is negative charge, isn't it? So ion transfer. These two is important for your uh, sodium reabsorption process. Okay, you need to remember these two. Okay. Another point you need to remember is distal convoluted tubule or DCT. Basically, the function is going to secrete potassium ion in exchange of sodium. So meaning that is cation exchange process, meaning that it's going to secrete potassium and then take back sodium. Okay. So loops is different story. In your loops of Henry we're going to perform uh, chloride ion transport because we're going to uh, deal with chloride. Yeah. In this loop, they are not going to deal with cation exchange and they're going to deal with ion chloride transfer. So remember. So, okay. How about proximal PCT and collecting drugs? Normally, ADH are contribute. So from there, I think you know already, isn't it? When the drugs is add on ADH, normally we focus on proximal convoluted tubule and collecting drugs. When the drugs is affected, the chloride ion exchange, we're going to focus on lobes of Henry. And also when the drug is causing effect on uh, cation exchange, will definitely happen in your distal convoluted tubule. Clear, isn't it? Okay. That's why I the purpose of I putting this slide is make you understand before we go in detail. So this example, you can go back and appreciate. Go back and go through. Okay. This is another slide. Illustrate the whole pictures of directive. Okay. Osmotic directive will focus on this zone, which is glomerulus. Carbonic anhydrase inhibitor will focus on PCT. Uh, your loop directive will going to focus on Henry loops and thiazide potassium sparing diuretic ADH, especially thiazide and potassium uh, sparing diuretic will focus on your DCT, and ADH will focus on DCT and also your collecting dot. Clear? Clear. So, how about renal functions? What is the conditions associated with renal functions? Just now I mentioned, isn't it? Nephritis is one of the main contribution for renal failure. Okay, nephritis. Okay. So your renal function will be altered by your renal disease and or your cardiovascular dysfunctions. Okay, clear? These two conditions are directly contribute to your renal functions. If let's say your heart can perform normally, uh, then we can say sometime or very rare you can get renal dysfunctions. So few symptoms you need to understand. One is oliguria, means that you decrease in volume of urine. Then second one is anuria, totally you don't have urine. You didn't produce urine. So once you didn't cannot produce urine, what will happen? Toxic compound and ion will going to accumulate in your body. This condition we call it as uh, uremia. Uremia. Okay. And then normally this uremia will follow by edema and hypertension. Okay. So that's why uremia sometimes also known as toxemia because of accumulation of waste product, especially nitrogenous waste product, meaning that the waste product contain nitrous, nitrogenous. Okay. So edema and hypertension is normally associated with a rate of water retention in circulation system. Okay. Because uh, sodium clearance is insufficient. You cannot clear sodium. Since the column cannot clear, the sodium will stay in your blood circulation or certain location. Once stay in your blood circulation, the sodium will going to reabsorb water, and then the water will remain then there. So that's why cause edema and hypertension as well. Okay, yeah. So the first directive we are going to discuss is osmotic directive. So the example is gasoline, isosobate, mannitol, and urea. These four are the commonly used osmotic diuretic. Among these four, the most commonly used is mannitol. Okay, mannitol. Mannitol is useful for an urea and oliguria conditions for kidney patient before irreversible damage. Okay, irreversible damage means that totally damage. Okay, meaning that the patients we call kidney patient, renal patient still have some functions of kidney functions, some percentage of kidney functions. So as long as not totally damaged, you can prescribe this either one of these four drugs. So sometimes this mannitol may can use for renal failure, acute renal failure, and cardiovascular surgery. Means that you're doing cardiovascular surgery sometimes may cause renal failure. Whether the renal failure can irreversible or not. Sometimes you do bypass surgery. Once you finish the surgery, sometimes may cause renal failure. Mostly the renal, we cannot say the renal failure, renal dysfunctions mostly are reversible. Okay, reversible will take few weeks, then we become okay again. So, okay, another thing is what condition we can use this osmotic diuretic? Cerebral edema, glaucoma. Okay, we can use mannitol to treat. Okay, but mannitol is not a perfect agent or directed agent because this basically this osmotic diuretic group is low intensity, meaning that just now intensity the definition we do discuss, isn't it? Cannot excrete more sodium, and that's why limited clinical usage of these drugs. Only certain condition you can use these drugs. So this cartoon are showing the mechanism actions. If you got time, you go and read this cartoon and you appreciate this cartoon. This cartoon tell you everything about this osmotic diuretic pathway. Okay. So what happened is okay. The mechanism action is very simple. Okay. The compound we are going to enter, we are not going to reabsorb. We are going to enter after filtration into your tubular or Bowman capsules, meaning that the compound. Look at this small figure here. The green color indicate the uh, osmotic diuretic drugs. So once you give to the patient, normally they akan pergi ke your Bowman capsules. Once enter your Bowman capsule, what will happen? This drug will going to absorb water. Okay. from your blood vessel. Okay, absorb water into the tubular, and finally the water we're going to excrete out from your collecting drugs. Meaning that this drop we're going to create a osmotic gradients. Okay, this osmotic gradient going to capture water from your blood vessel into the tubular. So by doing so, you can excrete water from your body. So that's why no major alterations of sodium resolve for this group of compound, meaning that they are not playing around the sodium reabsorption. They only cause osmotic gradients. So since they are not going to play around or alterate your sodium reabsorption, that's why it's considered as mild diuretics. Diuresis means that the effect is very mild. Diuresis, podium, very mild diuresis process effect. Okay. Another thing is not going to alterations in the ion and base, acid and base balance. Certain drugs do affected your pH, but this drug we are not going to affect your pH because why? Very simple. These drugs are not going to alter your sodium resorption. That's why, or your electrolyte. That's why we are not going to alter your pH. Clear? So normally given intravenously, especially mannitol. Some of them can be given orally, but we don't normally given intravenous because cannot able to penetrate your cell membrane. Meaning that when you give them by oral, then the drug cannot able to absorb. Okay, so uh, gasoline isosulfite sometimes given orally or mainly given orally, then the diuresis process may up to 6 hours. Okay, the diverse effect is quite clear. Nausea, dizziness, headache, and chill. Okay, this is a common uh, side effect of diabetic. So the patient when you given mannitol to the patient, then the patient should under close observations because of the side effect. Okay, clear. So another thing, if let's say the patient is have cardiac functions disorder, bear in mind you need to bear in mind they are going to increase the plasma volume. So sometimes contraindicated with the treatment of cardiovascular insufficiency. So it's contraindicate contraindicate. Because why? Because they're going to produce plasma volume, increase of plasma volume, meaning that your blood volume is going to increase. That's why for edema, we are not going. The idea treatment is trying to reduce the plasma volume, isn't it? But for this treatment, they we call it as contraindicated because it's going to increase the plasma volume. So it's not suitable for certain condition. So when you want to use this drug, be careful. You think twice before you use. So this is the range of the drugs and in how when you're going to use the drugs. For example, guys, mannitol used for glaucoma or for example. Uh, okay, finish the first drug. Second drug we are going to study for today is carbonic anhydrase inhibitor. So since is an inhibitor means that the drugs is inhibit this carbonic anhydrase, this enzyme. So that's why we call it as inhibitor. The example is acetazolamide. methazoamide. These two are the famous example for carbonic anhydrase inhibitor. Okay, normally used for gout. Sorry, not gout, glaucoma. Okay, glaucoma. Because able to eat, because this carbonic anhydrase play an important role in glaucoma. That's why it's suitable use for glaucoma. So before we go in detail, so the definitions of glaucoma is increase the blood pressure of your eyeball. Okay, this condition we call it as glaucoma. Why? Because your eyeball, uh, normally they're going to produce uh, fluid, isn't it? Fluid. We call it aquasa. Why your eyeball need to produce aqua? Because they need to reserve the structures of your eyeball. Okay, that's why always produce aqua. But in normal condition, this aqua we're going to excrete out, drain out. So through this tubercular meshwork, when you produce your aquas normally will drain and then enter this location and then excrete out. Okay, excrete out. But in certain condition, because of your defect of your anatomical structures, then your trabecular meshwork is obstructed. So even though, not even though, the fluid that you produce are not able to drain out. That's why you can cause glaucoma. So this condition we call it as close angle glaucoma or narrow angle glaucoma. This is a normal one. So why open angle refer to the iris? There's a space between your iris and cornea. There's no blockage of your trabecular meshwork. Then we consider as open angle. With narrow angle or close angle, then refer to uh, there's no space between your iris and cornea because of the structure's defect. So the functions of carbonic anhydrase is going to produce water. Okay. And then this water known as aqueous humus, aqueous humor. Then aqueous humor. So if let's say you're able to inhibit this carboxy anhydrase, meaning that you're able to decrease or inhibit the productions of aqueous humor, meaning that you're able to control the pressure of your eyes. Okay. So the side effect of uh, carbonic anhydrase inhibitor is myotic. Myotic, and because of myotic, so you may ask me how we know that we are suffering from glaucoma. The simplest or straightforward symptom is your eyeball is very painful. Okay, it means that your eye you feel painful in your eyes. So you need to check. How your doctor going to check? Simple only they ask you to open your eyes. Uh, then they will spray anesthetic. Okay. Then they will use a special tools, some sort like hammer. Then the tools will produce a pressure, and then actually the tools is some sort like hammer, and then they were going to uh, shoot shoot a special things from the front of the hammer. Then the thing will when touch your eyeball will reflect back. From there they can estimate how many pressure inside your uh, eyeball. Okay. Once you've been diagnosed as glaucoma, you need to receive, you need to receive a proper treatment. Otherwise, you may damage your retina and then you may damage your retina and become blind. So bad, man. We got one like my teacher, my teachers, one of my teacher eyes was blind because of this glaucoma. Because he didn't realize that he has glaucoma. At the end, when he can't see, one eyes become blind, then you only go and check, oh, definitely he have glaucoma. So uh, another usage of carbonic anhydrase inhibitor is for the treatment of epilepsy. Epilepsy. And beside epilepsy, this carbonic anhydrase inhibitor also used to treat acute mountain sickness. What is acute mountain sickness? Okay, acute mountain sickness is is a condition when you change the attitudes. Okay, change your attitude dramatically. For example, uh, 5 minutes before, then you are in zero sea level, and then 5 minutes later, you are in 400 or 4,000 meter above sea level. Then we can consider this condition. We can consider as change your not exchange change altitude level significantly. So may why once you change so fast, your body do not have enough time to adapt to the environment. So you might have acute mountain sickness. So you can use this drug to treat. So the mechanism of action is quite simple. Okay, uh, will cause sodium and water excretion by inhibit the enzyme carbonic anhydrase. This is the mechanism of actions. Okay, because why? Your carbonic anhydrase we're going to convert and then produce hydrogen and carbonate here, carbonate here. So this hydrogen is very important for sodium exchange. So without this hydrogen, you are not going to perform sodium exchange. So that's why it can decrease your sodium reabsorptions. So by doing so, your sodium will not going to reabsorb, will stay in your tubular. So it cause diuresis effect. Clear, clear. Since the carbonic anhydrase inhibitor involve uh, the productions of carbonic, that's why these drugs might alter your body pH because of carbonate. Go back and see. Good. So in normal condition, your and carbonic anhydrase will going to produce carbonate and hydrogen. So once you inhibit what will going to happen, you are not encourage the productions of carbonate. So once you do not have sufficient amount of carbonate normally will act as a buffer. So your pH will going to change, may affect your body. Okay, may affect your body. May cause metabolic acidosis. Clear? So normally this group of drugs is can be given orally. Uh, the drugs is will not metabolite in your body, uh, and then will excrete out as what you given the form that you given to them, the structures you given to your patient. Meaning that what they absorb, they were going to excrete out in the same structure without undergo metabolism. Okay, clear? So, so the side effect is hypokalemia, hyperuricemia, metabolic acidosis. Okay. So those patients already have metabolic acidosis should not given this carbonic anhydrase inhibitor because we will worse the conditions. So another thing is even though the patient is a glaucoma patients who have renal disturbances and meta depression or electrolyte imbalance, you also should not prescribe this one, even though it's quite useful for glaucoma patients. So until now, okay ka? So until now, this okay. So we stop here. Okay, yeah. Then you prepare for next lecture. So we continue next week. Okay. Bye bye. See you.
Thank you, doctor.
Thank you, doctor.
Okay. Bye bye.